The goal was pretty simple. I wanted to remove any hesitation. So I wanted any nurse from any unit could call a nurse consult and say, hey, I'm worried about this patient, without having to prove anything first. Understandably, the call could be not just, hey, I'm concerned. The call is like, I need help. Clinical judgment, it gives flexibility. It's your ability to adapt to the patient that's actually in front of you. And what worked well for us in standardizing the trigger, not the treatment, is the biggest key for me. I do view technology coming into the nursing world more and more, and that we should look at it not as an expense, but as a strategic investment that improves the quality of care while supporting the people who deliver it. We're actually going to be able to predict what our interventions are going to do before we actually do them.
What's up, guys? Welcome back to the podcast. I'm your host, Kati Kleber. Before we get into the episode, wanted to give you a little update on Fresh RN. Fresh RN's going great. I'm loving getting up in the morning and working on what I'm working on right now. Probably the most excited I've been about this of a lot of the projects we've worked on. So I'm working on taking the best of med-surg mindset, according to you guys, and the best of New Nurse Masterclass, and creating a med-surg residency. So it's very specific to being a new hire on a med-surg unit. And we're going to do the same thing for ICU. Okay. Those will be ready to go by the end of the year. My hope is, to have those ready for people who are graduating in December, getting ready to start on those units. And it's not just for new grads, any new hire into those units, to really take that clinical knowledge and integrate it with the very practical, realistic being part of this new team on a med-surg unit or an ICU. I know a lot of you guys are experiencing various preceptors. These days, it's very rare for someone to have just one preceptor. Some of you have reached out and said you've had dozens. It's very difficult to consistently develop a routine with so many preceptors, and I want to provide something that enables you to thrive no matter who you're with. And actually, there's a big portion of it about working with preceptors and your team and how you can thrive no matter what's going on. So excited about that. Going to be ready by the end of the year. We're also making an enterprise version of that. So if you're a hospital and you're like, I need a resource to standardize this process that's not this really expensive, full out residency program, but more of a turnkey, nimble solution that plugs seamlessly into your existing LMS. You can assign the modules. You can have some discussion questions if you want, and be able to really support those newly hired people on those units in a pretty standardized way. So that's coming, and that's part two. So part 2 is 2026. So we got to get part 1 done. I'm gonna get that done. Can't wait to keep working on it. As soon as I'm done recording, I'm gonna do more of that. So that's what's going on at Fresh RN. Stay up to date on that. Be on the email list. I'll have a link in the description of this episode. If you are very interested in learning more about the hospital, the enterprise version, make sure you're on the email list. And I have a special list for people interested in beta testing it. So freshrun.com/enterprise. No, there's no commitment. That's just being up to date on when things are ready, what we're featuring. If you want to even, hey, there's some insight that, hey, I'm interested in something like this, but it's really got to have this. I do have some nursing leaders that are helping me develop it, but I would love to know if there's anything very specific while I'm in earlier development stages that I really need to consider that you would love to let me know about. So freshrn.com/enterprise. Now let's talk about this interview. Wonderful interview with Jaclyn Bond. She is a director of nursing at a hospital on the West Coast. She earned her MS in nursing leadership. She also has an MBA in healthcare management. Also, pretty cool. She got her BS in nursing from West Coast University. Leading in 8 specialties, Jaclyn excels in program management, budget oversight, and informatics. She developed a nurse consult process that empowered bedside nurses to activate the rapid response team, and also created a patient-specific fluid resuscitation protocol, both of which obviously improve patient care. It's pretty incredible. I can't wait for you to hear more about the nurse consult call. Pretty awesome. And then all this amazing sepsis work that she has done. Quick disclaimer, the views and opinions expressed in this episode are solely those of the guest and do not represent the official position of any organization with which they are currently or previously have been affiliated. So thank you guys so much for tuning in, and I hope you enjoy. Well, welcome to the podcast, Jaclyn. It is so nice to meet you.
Nice to meet you guys too.
So I want to hear more about your nurse consult call that you instituted. Now, a lot of people are probably familiar with the rapid response. So could you, well, maybe some people aren't. So could you explain what it is you instituted, how that differs from a rapid response, and how that differs from a for real code?
Sure, yeah. Yeah, so, I think everyone's familiar with calling an RRT, and, and I'm sure we all have different definitions of how we define what that is and what the criteria is, but essentially in my mind, a rapid response call or an RRT call is for a patient who's decompensating, but not to the point of cardiac arrest, or where we're having to perform ACLS, CPR, things like that. That's kind of the threshold of where then it turns into a code blue call at that point. So, RRTs are for those patients that are really declining evidently right in front of you on monitor, things like that, you would want to call a rapid response for. What I found, though, is, I was having lower calls of RRTs and higher calls of code blue, which is not ideal, right? You want to see the lower end of code blue calls and maybe a higher end of RRTs. But I found that a lot of times when we were calling RRTs, we were calling them almost too late. Like the nurses didn't feel comfortable calling sooner because the patient didn't really meet RRT criteria yet. But they felt like something in their nursing gut was telling them like, hey, this patient's not doing well. So I decided to say, hey, we're going to just make a nurse consult. Physicians get consults. Why can't nurses call in a consult? So
that is so smart. I didn't think about it like that. They do.
Yeah, they can call in consults and from, professionals all the time to get a second opinion. Why can't nurses? So I created a nurse consult call. It's an activation, silent activation, meaning it only goes through our paging system. It's not overhead.
Okay.
And it goes to only the rapid response team. And the goal was pretty simple. I wanted to remove any hesitation. So I wanted any nurse from any unit could call a nurse consult and say, hey, I'm worried about this patient without having to prove anything first. And I just found like that one little change made a huge difference. It really took away the fear of being wrong and replaced it with some sense of like shared responsibility between the rapid response nurse and the bedside nurse. And it was essential really for our new grads.
Yes.
As many people probably have, several new grads coming through our organization. Our nursing field has really picked up on desire from our younger youth wanting to become nurses, and so we're seeing more new grads, and they needed the most support in my eyes, understandably, and fostering a culture that allowed them to learn and become better nurses is ultimately what my goal was. And I wanted to build the trust between the bedside nurse and the rapid response team and even physicians, and encouraged earlier escalation and helped us intervene before that patient deteriorated. And what we saw as a result of that is you saw higher instances of nurse consult calls and RRTs and lower calls of code blues. So you could see the shift just in those metrics, that we were changing their mindset and they were calling sooner and we were intervening before the patient actually deteriorated.
Please tell me you wrote this up to present at conferences. Oh my gosh, this is amazing.
Well, thank you.
At the bedside, that nurses are just brand new ones, so intimidated. And those rapid response nurses, sorry guys, I love y'all. You're intimidating because you're so smart and you're so assertive. And it's the big fear is to call them and for them to come and be like, well, you didn't need to call me for this, So they wait. I waited. I mean, I know people that did. And the only way I feel like at the bedside, the only way you knew to not wait and call earlier was when you already developed rapport with those people.
Yes. Correct.
So you were you didn't feel like they were going to judge you, you know?
Yeah.
Not
Absolutely.
that every many are all very, very nice and wonderful clinicians. That's why they're in that role. But it is such a barrier. Wow, that is incredible. I'm really impressed with that.
Yeah, RRT nurses, and just, if you're new coming into the world, I can understand. I saw it firsthand when I was a rapid response. It's not even their personalities or anything like that. It's just the observation of how good they are. And being a new grad, just watching a nurse be so amazing in a situation that you can tell is just second nature to them. That is already intimidating off the bat. And honestly, you can go talk to that rapid nurse and they're probably the nicest person.
Yes.
It's just their persona of their presence in the room that becomes intimidating, I think.
Well, and in these situations that they're called into, they immediately, those are very uncomfortable situations for most people. Yep. And then you're in an oftenly emotionally charged, tense, time-sensitive situation where you have to assertively advocate maybe to physicians, sometimes to families or even patients themselves, and they just like flourish in that environment. Totally. And that you're, as a new grad, through no fault of your own, you're very far away from being like comfortable like that. So it's not only, and then that's not even talking about the actual clinical stuff of them knowing the questions to ask and what about this and what about that, and then the doctor say, oh yeah, you're right, you know what I mean, like it's just like a big scary thing, and you don't want to, you want them to like you too, and you want them to think you're smart, and there's so much weight that goes into that theoretically you should be able to not have that barrier, but that's not reality, right?
I know. You'll get there though. For any new grads listening, just hang tight. You'll get there.
Now, now in your hospital, RRT, are those, is that a separate department from ICU, or does the ICU nurses fill that role?
Yeah, that's a great question. So I worked at a few institutions and everyone kind of did it differently. I worked at one institution where RRTs were called and someone from the ICU responded, which is, I think, a more similar classic role that we've seen. And then I worked at other institutions where we had rapid response nurses that were their own department and their own entities. They didn't belong to any unit and they never took patient care assignments. So it was a full-blown 24/7 team, and they responded to all activations, honestly, throughout the hospital except for traumas. And they responded to everything, code blues and strokes and sepsis calls and PE. So they responded to everything. And working at all of the different places, I've just personally found the model of having a dedicated team was the best. And so I saw the most output from that side of choosing how to build a RRT team.
Yeah, I bet you have to have like maybe those pretty small hospitals. They probably can't do that, but as soon as you get to be a bigger size, I bet that makes a lot of sense to have that dedicated team.
Yeah.
Hospital I've worked at two that did opposite ways, and those ICU nurses that were like, oh, I'm on RT today, because you never know when you're gonna have to like leave the bedside, which is extremely stressful. So that's interesting. Do you see what kind of calls is it mainly like a sepsis and those kind of disease processes where you're seeing people initiate a nurse consult? Because a sepsis is definitely one of those where it's subtle and like, hey, wait, there's these little things going on, but I'm not sure. It's not an emergency yet. And honestly, I think back to my RRT calls of calling them. It was almost always sepsis.
I know. Yeah. I would say sepsis is up there when I look at nurse consult calls. Sepsis is one of the higher ones, for sure. We've done it to where nurse consults can happen in the emergency department, where about 95% of all sepsis cases are entering. So we call, and it's really because we need help with, those demands of what a sepsis patient is requiring. So understandably, the call could be not just, hey, I'm concerned. The call is like, I need help. Like, I need help getting all of this stuff done. And so they could call for that as well.
Oh, that's amazing. I mean, I can't think of how many times I had where that would have been like, yes, sepsis, you have to get done very quickly. Well, like in the neuro ICU when they're not coding, but it's like a neuro code where we need, we need to get an art line in, we need to do this, and
I need help.
You physically can't do it all. And those new grads feel like they should be able to, and then they end up floundering like we would, because there's not enough people there. You need like 10 people working at once to get this done in the time it needs to be done.
Yeah. And it's hard to turn to your, colleague that's also taking care of 2 really sick patients, say, hey, can you come help me, when they're like, man, I'm stuck with my pressors on this side. So having that option available that you can just say, hey, I need some help, has really done benefits. And I mean, they could get called just to help transport a vented patient to CT. I mean, you have a high critically vented patient, it's just you and RT.
Yeah.
There's several times that, and this is, again, if you look at a rapid response nurse, they're highly skilled, educated, trained, and they're just being called to help transport. And that, as mundane as that might seem, it's not at the bedside. That is a super critical thing to have comfort knowing I got this 16+ year nurse next to me who's going to be there to support me if anything happens.
Lord.
It's amazing. It's amazing to watch happen on the sidelines and watch that relationship develop.
Yeah, and then probably those new grads can kind of like relax a little bit more and learn faster, because you're so scared of what you don't know when you're dealing with these super sick patients. That makes a lot of sense. Wow.
Totally.
So when they put in, just operationally, are they putting it in the EHR? Are they just calling and say, hey, come help? Like, how do you you just call? Now, do you guys how do you document, like, does that RRT nurse document the call and what it was for? Like, I'm just thinking, like, operationally for management who might want to institute something like this, like how, that kind of side of things.
I don't put it in the, I didn't require them putting that into the EMR. Like, there was nothing like that. They just had to call our operating system and say, hey, I want to activate a nurse consult on this bed. Or sometimes they just directly called the rapid response nurse and say, hey, I need a nurse consult.
Okay.
And then I did want to track some data to see if I could pinpoint any changes in variance in the data to say, like, hey, this is when we initiated, nurse consults versus, whatever it might be. I wanted those moments. So I did have the rapid response team just document in our own personal database every call they went on, what unit they went to, and we categorized each call. So I didn't need a specific, like, I took patient in, 6-7 to, CT, and then from CT, I didn't need that. I just needed, like, hey, I went to a transport call today. I went to a deteriorating patient call today. I went to, X, Y, and Z. And then one thing I also collected in the data was the outcome of the call. So were we good to go and we could walk away? Did they escalate to a rapid after you got involved because you were seeing what the bedside was seeing? Did they code? So did they get upgraded after you responded? Things like that. I would start to kind of keep track of data and what the outcomes were.
Now, did you find anything surprising in that data?
So I found, what I was surprised is I found they were being called a lot for IV starts. And
really?
I was shocked because I was like, man, IV start. But then I had to think, okay, so what units are calling? Okay. And I was finding it was like more med surge and things like that. And then I had to stop and think, like, because I come from a ER trauma IC background. And I'm like, I don't know if I would ever call besides having a PIC nurse come and put a PIC line in. Like, how are they calling? And my snap judgment came in and I'm like, man, they're just using them kind of thing. And then I had to stop and think, like, well, how often do the patients arrive to med surg already with their lines placed? Like, how common is this, that's happening and things like that. So that was my most surprising that I found. Other than that, the second thing I found surprising was the amount of calls. And at first they were very slow and far few between. And then as people started realizing, hey, you could call this nurse consult, and like it grew, man, I saw them go up. So we almost had to tighten a little bit on when you
parameters.
You can call. Yeah. But for the most part, I thought that was great because as I saw those going up, guess what I saw coming down? Were, code blues, upgrades, things like that.
That's got to be incredible. And not only is that improving patient outcomes, I'm assuming, because we're reducing like codes and things. That probably is a big cost savings too. And like, there's just so many beneficial things from that
Totally.
piece being added. That's funny about the IVs. I spent time on a med surge in the med surge world and the ICU world, and yeah, like half the time they come with an IV, and then and if they come from the ED, and then if they come from the ICU, half the time they'd have a central line.
Yeah.
So it's like,
what is how often are they really getting experience?
And when you're a new grad, you're not on a med surge. You're getting it less. It's not like you spent 2 or 3 days in a 1-day surgery and just put in 50 IVs. And a lot of them are not getting experience in school. So then they're like, I remember on my, I was not the best IV starter. But with the couple people who were on our unit were like the go-to people, and they were ones who worked in 1-day surgery or the ER. Yeah. Like they just had all this experience, and you avoid that, starting an IV when you don't feel confident with it on a patient you're going to have for 12 hours. Yeah, it's tough. That's definitely one of the skills that students or new grads reach out. Like that's the most they're nervous about, which I very much understand. Now, did you have any challenges with implementing something like that with leadership? Were there any like institutional barriers that you had to like navigate? Is that a silly question? Because of course there were.
Yeah, no, I didn't get to walk in and get like the golden egg handed right to me. Right. No, I mean, and understandably so. And being on the other side of the curtain and being in a leadership role, I get it. Like I totally understand, because they have a new lens that many people at the bedside, we don't really have that lens. We don't worry about the financials, and, essentially it is a business. We have to make sure we make money in order to care for patients. And like, there is a business aspect to running a hospital. And I think sometimes at least I could say for sure, I didn't see that completely. Yeah. So when I first stepped in, my role was mainly focused on sepsis. And I realized that what we often underestimated, meaning leadership, wasn't staff knowledge. It was the reality of the bedside, what's actually happening at bedside. And I was expecting nurses to hit, these time-based bundle targets without fully appreciating like how many obstacles were existing between the recognition and action. And they were simple things that were barriers that I think we oversaw. Things like waiting on pharmacy to either mix an antibiotic or deliver antibiotics, locating pumps and
oh Lord,
finding hidden pumps, and getting lab draws processed quickly, or even finding providers to place orders. All of these like created delays that weren't about motivation or competence. They were about workflow design. So to me, another thing we underestimated was, also the emotional, sepsis cases, and how they can be that emotional for nurses, because we feel the weight of those rapid declines. And when systems make early action hard, it breeds frustration and guilt that we don't always see from the office end. And I've experienced it, I've experienced firsthand stopping and asking like, why. I didn't want to ask anymore, why didn't you get this done? I wanted to ask, what got in the way? What was the reason that you didn't? Because I know nobody comes to work saying, you know what, today's the day that I'm just not going to care. And, they're not coming there to not get things done. Right. So that was a culture shift that I needed to realize on that leadership end.
Wow. Yeah, that is incredibly insightful. Because nurses, you have to enact something that requires so many different people to do things or processes to work, but you at that bedside, because you're the one looking at that patient in their eyes and they're terrified, and you got to bear that weight, and it is heavy. Oh my goodness, that's whew. So so that leads me into, because you also have done quite a bit of work with, in addition to the nurse consult, you've done quite a bit of work with sepsis in general, right?
Yeah.
Tell us more about that, because clearly you're very knowledgeable about sepsis and the operational aspects of providing that care.
Yeah, so, I mean, sepsis is, I think, I don't want to say new. It's been around forever. I mean, it's I think it's like the third leading cause of in-hospital deaths is related to sepsis. So, I've just been involved in learning that process and, the hemodynamics that go around sepsis and, why we're doing what we're doing and things like that. But more so in the last few years, obviously it's picked up steam because now it's part of our CMS, reimbursement rates. It's going to be measured on how much we're going to get reimbursed by CMS starting, honestly, the charts this year. So I've seen it just pick up some steam. And so, and I think a lot of hospitals are feeling that now, because now we're going to be held to these, these metrics and standards that we might not all agree with. And so how do we work around that? How do we get those things connected is really the new norm for us.
Yeah, I feel like when I was taking care of those sepsis patients, you have all these protocols, which are great, but then you also have these physicians are like, this is too much fluid, not enough fluid, this doesn't work for this person, and do this, and then it's like, run the sepsis protocol, but here, do 20 exceptions, and like it's I feel like those protocols can be extremely helpful. Oh, but they can also be tough at the same time.
Totally. Trying to balance standardization versus like clinical judgment. Oh man, that was always constantly on the forefront of my mind, because the new standardization for SEP by CMS and SEP 1, it has created this naturally where it's affecting what we feel as clinical judgment, because I view standardization as, it provides the consistency. It's your safety net. It's what we're consistently going to always do this with standardization. Clinical judgment, it gives flexibility. It's your ability to adapt to the patient that's actually in front of you. And what worked well for us, and that I've seen at institutions that have adopted this, is standardizing the trigger, not the treatment, is the biggest key for me. So everyone use the same recognition. Everyone needs to use the same escalation process. But once sepsis is confirmed, then the nurse and provider should have the freedom to individualize the care based on the response of that patient. And so that structure, it keeps everyone kind of in line without removing that critical thinking from the question. And so I just learned from experience and observation that if you over standardize, we unintentionally teach people to just stop thinking. They just follow steps instead of reading the patient. And that comes from over standardizing things and, wanting to gain control and control the environment. But when we, set clear expectations around when to act, why, while leaving room for professional judgment in how to act, it builds confidence and accountability for all.
Wow. That was, I've talked about standardized order sets and, everything from an admission order set to whatever, like those things are very helpful, but you get, especially when you get work in a teaching hospital, you've got residents who are just learning the flow. Yeah. And it's like, oh, I just implement the order set. And then, but then you look at the order set and it's like, wow, 30% of this is not appropriate for this patient. And then you know what I mean? And then if you're just doing that all the time, you're not thinking, wait, what is appropriate for this patient? And how many times it'd be like, this person can't have this kind of diet because of this, and they can't have this med because of this, but it's on the stroke order set.
So what am I supposed to do? Yeah.
Right. And then they get mad at you because you're like, why are we doing this? Yes. But that's such a good point. It really does limit the critical thinking, because you just, I just do this, and it puts in the 50 orders instead of me having to go through it all. So that really can long-term handicap your thinking.
Absolutely.
Oh, that's such a good point. Especially with something so dynamic as sepsis.
Absolutely.
So many changes and things. So, like, for example, I love the not the treat, standardize the trigger, not the treatment. So just like practically, how would that look? Like, it may be a sepsis, or like, okay, so when their lactate is this, then call, or like, what is that?
That's such a good question. I mean, I haven't seen it fully developed, yet exactly how I would want it in my mind, because everyone is going to have different barriers and things like that. So, but ideally how I would imagine it to go would be, you do have, this is where standardization and clinical judgment. So there's a standardization on what is defined as severe sepsis and septic shock. I can get behind that. I could use that as the standardizing of the trigger. So I kind of use those definitions set by CMS on saying, they have to have 2 SIRS, a suspected or known source of infection, and then 1 organ dysfunction. And we define that for everyone. So there's my standardization of trigger. So
I see.
I would use that, and ideally I would like the process to go where this is more nursing led. Nursing is driving these actions between the doctor and the patient. And so if a patient comes in and they're 2 SIRS and maybe they don't have an organ dysfunction yet, or we haven't assessed, a nice huddle happens between the nurse and the doc and say, hey, do we think we want to go down the sepsis route or not? And then they'll talk about it and say, I think this is more sepsis. They were complaining of flank pain, and let's go down and let's evaluate for organ dysfunction. And then they both do this assessment either through labs or physical assessment. And if one of those organ dysfunctions that we have standardized as to trigger occurs, then boom, that's when you should start your whole sepsis bundle. And that's where you put in your consult or your rapid response and get all the right players to the bedside.
Oh, that makes so much sense. And then I like the standardization because it also does take a little pressure off of the nurse a bit, because if it's very, very clear what these triggers are, it does remove some pressure from those nurses.
Yeah. And it follows the standards and guidelines set by CMS, and so you're kind of hitting 2 birds with 1 stone in that regard.
Yeah, and then because I guess I'm curious if you're aware of, or how physicians view nurse-led protocols, and if it's difficult from a leadership perspective in terms of getting those kinds of things implemented. There's a lot of nurse-led protocols, and I love them. Obviously, we need some great data to support them. Do you see it? Are there?
I was literally just gonna say,
get good data, and then they'll do it.
I mean, honestly, I just found my biggest weapon was data. Because I always numbers don't lie. You look at data, and it's very honest. Candor tells you exactly what's happening. So, when I was leading, the sepsis improvement efforts, data was one of my biggest allies. And I specifically tracked nurse-driven sepsis activations and looked at how they affected the outcome of the patient. And the data was, making the data tell its powerful story that I knew was happening. So that was essential, because it wasn't the data we were compiling and analyzing. It wasn't about compliance. It was about impact. I can look and say, how many times has a doctor put in an order set and how compliant were they? But if I can't respond to the second half of that of, well, what's the impact it's caused, then the compliance rate really doesn't matter, right? I don't know what effect it's having.
Yeah, so, who cares if they're compliant if it's not moving the needle in it?
It's not moving the needle. So seeing those measurable decreases in, let's say, time to antibiotics or fewer ICU transfers, that got a lot of attention, because what really shifted the mindset was when we connected that data back to the individual patient. So we were able to say, not just our mortality rates have decreased, but we're able to say, hey, that patient didn't code because someone recognized sepsis early. And, bridging that gap between analytics and empathy and using data to make the human story visible, it really, really changed the game on how people were seeing, our sepsis initiatives. And the second half of this, I would say most important is learning to present the data to the right audience. So, with physicians, I like to focus heavily on what outcomes and physiological rationales there was on what these activations and what occurred. With the executives and chiefs, I try to tie in what the ROI or return on investment was for what they invested in, and the resource utilization I was doing to accomplish all of this. And nurses and bedside, I showed how their actions directly influenced the metrics that mattered. And I showed them exactly what they were doing and what their actions, how they were affecting the outcomes of these patients. And once everyone could see their fingerprint on the data in some way, the buy-in became just ownership. And that's when it really stopped being, here's our sepsis initiatives, and started being these are our sepsis standards. This is why we do what we do. And so physicians seeing that, to go back to the beginning of the question, physicians seeing that, they were seeing the results and outcomes of this nursing-led standards we were setting for our sepsis activations. and they had buy-ins. And then honestly, it took pressure off of them too. You know, they knew they could trust the nurse to when they were coming and escalating things, it was for a reason. So again, it was just nice to see all that. But data was my ally to get all that.
Wow. Like crafting the message for the person, the role, and what's most important to them is so critical. And that's something too, I think managers who are start in the management role, and that's probably a difficult thing to identify, learn how to do successfully, to implement change. Because you do need to talk to the nursing staff to get them to like buy in and have that ownership very differently than your providers. Like there's just a different touch point. Yeah, and it's like you tell the nurse, you're gonna save us like $3 million. Great job. Like who cares? Who cares? Like they're the ones seeing the people suffer at the bedside and the
as you just got me like pizza last week. Like they're you know, that's not
that's toned down. Like we can't do that. Like so that makes so much sense and from an operational standpoint to like implement something, but making sure as part of that to have the data to back it up and talk to all the stakeholders in language they can understand and appreciate.
Totally.
Well, that was like a couple of my questions, like all wrapped into one there. I loved that. So, is there anything, because I have a lot of listeners who are in a management role, might be at like a smaller kind of a hospital setting, resource limited. Are there any lower cost quick changes that people can do to support their nursing staff to meaningfully improve sepsis outcomes? Like that might be able to move the needle for some smaller places. I know, because like a lot of hospitals that are large have great resources. Then you get to these smaller community hospitals that are dealing with sepsis, and that can be difficult to navigate.
So I kind of have a twofold for this question. So, you know, finding lower costs to help your sepsis program is the end goal, but I feel like you need to find what the hidden costs are for. So what's costing you the most when it comes to your sepsis care? And it could be something as simple as like, hey, it's the blood culture bottles we're buying and we're using more now because we're required. So there's little things. So you have to kind of figure out what's costing the most in sepsis care right now. And so when I took over the programs that I've been involved in for sepsis, I've just, wanted to see and appreciate how significant fluid overload really was. And that was throughout all of the programs I've been involved in for sepsis. That has always been the number one thing that's causing the most cost. And it's not directly like one bag of fluid is costing me.
Right.
Even though that was an aspect, it was the secondary harm from overloading our patients. And many of us have probably very familiar with the give them 30 mLs per kilogram phrase. It's probably all in our protocols and our standards, and that's corrected. That was a standard from CMS for years. But what I saw was when we overloaded patients, we were giving unnecessary volume that led to pulmonary edema, renal stress, prolonged recovery. And operationally, that was translating to leadership, longer length of stays, more days on vents, higher readmission. All of those come with a dollar amount attached of cost and what that was costing us. So when we look at saying, how do we want to reduce costs in, these institutions, we need to know what, the hidden costs were, what is actually affecting it. And so if I break down, how did I overcome these costs? Well, I needed to start to shift the focus on fluid. That was going to be my number one thing I was going to tackle. The biggest fallout for CMS was fluid. Our patients were dying because we were giving too much fluid or causing more injury because we were giving. That was my first initiative that I wanted to continue on and tackle when I got to these programs. So that's where nurse-driven dynamic assessments were created. We were creating nurse-driven bedside hemodynamic assessments, and specifically carotid flow time. And that was a game changer. So we were using carotid flow time, which is measured non-invasively on how long the blood takes to flow from the carotid artery during each cardiac cycle. And it acts as a quick indicator if the patient's cardiac output is going to even respond to fluids before we give them. And so we captured the carotid flow time during our sepsis resuscitations for any patient that met severe sepsis criteria and was hypotensive and going to get fluids. We needed to capture the carotid flow time, and we wanted to make sure that the fluids we were giving were actually needed for the patient. Were they going to even respond to the fluids before we gave them? And we used that. We capture carotid flow time using a device called the flow patch. It's a small wireless Doppler ultrasound sensor, and it's placed right over the carotid artery, and it provides real-time blood flow. So we were using this device before and after every bolus to determine, one, are they going to respond to it? Yep, they're going to respond, give them the fluid, and then reassess. And we do this circular motion until the patient no longer responds to fluids or is now normotensive and perfusing great. So making that change, we were only giving fluids exactly when the patient needed them, and it was being more prescriptive. So it was we bring back standardization versus clinical judgment.
Right.
I was standardizing, but I was allowing room to treat the patient in front of me. And we took it one step further too, and we actually had our rapid response nurses get trained to perform bedside ultrasounds, or POCUS. Many of you have heard of POCUSes. So my rapid response nurses, when they call for a sepsis activation, they'll come to the bedside and they'll grab the ultrasound and they'll do a point of care ultrasound right at the bedside. They'll capture the IVC collapsibility. They'll look at VTI. They'll look at the dynamic ability of the heart, see if they're hyper. They'll look for B lines, and they'll capture those images and they'll bring them to the provider and discuss what they're seeing, and the provider then determines what to do next. It's an extra tool in their tool belt. So mixing all of these things, I saw a big change as far as what our outcomes were looking like. And I was seeing the decrease in cost because we were using less fluid. We were intubating less. ICU admissions weren't as high. Our length of stays were going down, and our mortality was just as evident as that our mortality was decreasing. So I could see doing this patient-specific resuscitation was really benefiting. And so now you talk about, well, what are some low costs for smaller hospitals that might not have this big budget to create a whole team and things like that. So and there was a day and a time and place where these programs that I had been involved in, we started with nothing, or we had very little resource. And so we did have to make some low cost changes to make a difference. And so when I think about meaningful improvement, it often comes down to two things for me. It's clarity in the workflow and removing barriers that keep nurses from acting quickly. So if those are my two goals on when I'm going to initiate a change, then you're going to always be on the right track in my mind. So I looked closely at the steps between recognizing sepsis and treatment and asked, where are my nurses getting stuck? Most of the time, the barriers were very simple: waiting for orders, searching for supplies, things like that. And then knowing exactly who to call was another one. They were having these barriers from recognition to treatment. Mm-hmm. But by standardizing those steps, so when do you escalate, who do you contact, and what happens next, we eliminated all that confusion and built, consistency across the system. So that's a low-cost change. You're just improving your workflow. You're standardizing workflow and allowing them to have that confidence on what to do next. At the same time, though, I do believe in investing in technology that creates a win-win, where you're improving workflow for nurses while delivering high return on investment for the organization. I feel if you go to any conference, there's so much out there now that I can imagine sitting there as a new grad, sitting like, wow, if I only had this device, or if I only had this to help, like imagine how much nicer it would have been, or things like that. And so I do view technology coming into the nursing world more and more, and that we should look at it not as an expense, but as a strategic investment that improves the quality of care while supporting the people who deliver it. If we look at technology like that and pick the ones that are going to give the highest return on your investment, but also accomplish both of, cost effectiveness and truly supporting your bedside nurse, then it would only be a win-win. And so you don't need to go pick the $40,000 or whatever it could be, product out there, but if there's something that you could justify that will have this big return by improving the patient and improving your nurse's workflow. Those I found were key in investing in.
Oh, that makes so much sense. Like the almost no cost aspect of like, wait, let me just critically think about what those barriers are. Because yeah, with nurses, it's like they don't want, especially those new ones, and I bet a lot of hospitals, especially smaller ones, are having a large volume of newer nurses.
Absolutely.
It's like, oh, I have to call them now. They can't be mad at me because the protocol says I have to call them now or notify them or whatever. Like, just what a relief that is. Like, sorry, man. Like, that's just what I'm required to do. Like, that kind of thing is so helpful. And then to like, when you explain the hidden costs and just really assessing that, like those are millions of dollars that you're talking about.
Millions.
When you add increased length of stay, ventilators, like all these complications, and that's just like the dollar sign, let alone the human suffering added to it. And then like, so a device where you can like, oh, let's see if they're even going to respond to this fluid.
Oh,
like
it's
that,
a
just
game changer,
right? Like that would be like, I'm sure that would pay for itself so quickly, but you do have to appreciate the hidden cost first, otherwise it does just look like an expense. But I have been at those nursing conferences where there's a million different products.
There's so much out there.
And these really lovely salespeople who will very much convince you that their new product is the best new product.
I know. So every product you want, I mean, you walk down, you want everything.
Everything. And then I remember I went to one of those, and there was actually the Lucas device. And I was like all in on it. And I was like, oh, this is great. So I went back to my hospital. I was on like the shared governance thing, and I wanted it in the hospital. And then I did the lit review and the cost analysis of buying it, training people, the rapid response nurse having to carry it. Like, and then it was just like, oh, wait. And then the data is like, oh, wait, this fancy device, I need to look at it from that much more of a granular thing, you know.
How much of it is really going to impact us? Yeah.
Right. And it might be great in other settings, like maybe out in the field, but like here, it just doesn't logically make sense. But I would always evaluate that. I would always do exactly what you did. And I would always say, like, you know, what's the training going to be like? How much does it cost per patient? What can I expect on it going to improve? And you have to do those as you walk up and down those aisle booths, because there's going to be things where, man, it sounds great, but then if you look at the grand scheme, 1,000-foot view, I'm like, man, I just spent millions of dollars and I'm getting only this little out, or something of that regard, versus like I could have gone this route and I would have hit nurse satisfaction, less cost per patient, and got even a better outcome. So you got to make sure you look at both sides. Oh man, it gives you an appreciation for people in leadership, because there's this constant pressure to like optimize. There's all these things you definitely need to do, and other kinds of like products or things you could purchase to help make their day easier or better outcomes. But then you're also creating another thing for them to do, and another thing to measure, and what's just as important as knowing what to do is what you don't need to do, which is why I really liked how you talked about the device to see if they need the fluid, because it's like, oh, let's determine if we need to do that, and let's not do it if we don't need to, because there's so many things you could do. It's just as important to ask, what can we stop doing, because there's so many things you have to do constantly. You can't maintain it like perfectly.
No. And that was also, I want to go back to like look at empathy part. The nurses were feeling better about what they were doing, because how many of even not new grads, just nurses standing at the bedside, and they get an order for 3 liters, and they're looking at this elderly person who's, you know, and they're thinking like, I'm gonna give 3 liters to this person, and it just you get that little, you know, nursing bubble guts, and you're just kind of like, I don't know if this is right. And now I was giving them an out to say, you can say it's not right. You know right now it's not right, and you have proof to say it's not right, and your doctor's on board with you saying it's not right. And so that was like, it brought back more ownership and you know, away from treating a measure and to treating the patient.
And it like that brings in this aspect of nursing that you don't, like, as a student and a new grad, you don't really realize is there. Like, you think, okay, there's a right way to do everything. I'm being taught how to do that, and now I'm going to get into the field and do it. And then the reality is like physicians are all trained differently, all have
Absolutely.
different preferences. They're reading personalities, you know, resources and research. Like, I mean, I remember just at the same ICU team, one ICU doctor always wanted to do this, and it was crazy to this other ICU doctor if you ever did that. And it was like, the sheer amount of nuance to navigate as a new grad was just so overwhelming that and it was part of the reality shock. Like, we don't agree on how to do all of this? That was such a big, so to have a standardized thing.
Totally.
To be like,
where you standardize that, but allow some autonomy for your providers. Yeah. Yes, agreed.
Yeah. So to kind of cap things off, what do you think in the next like 5-10 years as you see, I mean, technology's like rapidly evolving. Good and bad, right? Especially with AI and all that kind of stuff. I'm curious, do you see frontline sepsis leadership, patient care, like those kind of things changing drastically? What do you think these leaders need and bedside nurses kind of need to be like prepared for? If you talk to maybe nurse Jaclyn in 10 years, what is she going to say?
I think, my personal opinion is with this going into value-based purchasing program for CMS, there's going to be a very different lens on how we're treating sepsis patients. And organically, we're going to see the issues that we talked about today, not escalating early enough. Like, we're going to peel the onion back, and we're now going to discover the process that needs to be improved on how we're treating sepsis patients organically just by this requirement tied back to monetary incentives. So I think going forward, sepsis leadership is going to be really having to shift their mindset to a nursing-led precision resuscitation. I think we're going to have to stop protocolizing what the nurses do and allow them to be nurses and allow them to feel the competence and not have the fear of being wrong or fear that they overthinking or fear that they're going to embarrass themselves, and give the power back to the nurses, pull them away from behind the computer, and have more of a nursing-led precision resuscitation for our sepsis activations, where it's individualized, it's data-informed care guided by dynamic assessments. And you're going to see, I feel, in the next 5 to 10 years or so, it's already happening, where high notable publications are coming out and saying dynamic assessments for sepsis is the wave. And so I think nursing and nurses are going to become increasingly more comfortable in interpreting real-time physiological data. And that's going to be a huge opportunity, because we're going to be able to move from these static bundles to adaptive care, where the nurses don't just execute the plan, they're informing it. They're the ones that are developing it. And with tools like FlowPatch and doing POCUSes and, advanced analytics at the bedside, nurses are going to be able to assess in real time whether interventions are actually improving perfusion. And I think that's going to be the big game changer, where we're actually going to be able to predict what our interventions are going to do before we actually do them. And I think the future, it goes even beyond these tools, and it's about, literacy in outcomes. And nurse leaders of the future won't just have to manage, compliance reports. They'll have to be fluent in how the metrics connect to mortality, cost, and capacity. No longer are we going to be able to just put up raw numbers on a data sheet. We're going to need to explain how that's connecting to our mortality, our cost, and our capacity. And we're going to have to learn to use data the same way we use a stethoscope, to assess, to interpret, and to guide what our next steps are going to be. And so I think this is organically going to happen over the next 5 to 10 years.
Wow. That was really good.
I truly believe it. I see it happening now.
Now, when you say dynamic assessment, can you define that, what that would look like practically real quick? It's for people who might not be aware.
So dynamic assessments are assessments that you're using throughout the patient's resuscitation phase. It's not a static one-time measurement. It's where we're assessing and reassessing the changes of that patient's status. So a good example is, I'll go back to carotid flow time in the flow patch. So, being able to assess the pre-intervention and post-intervention of this patient using the flow time is considered dynamic. It's something that changes based off of an interruption or intervention that you can get consistently throughout the time. Static would be a blood pressure. That's a one-time intervention we're going to see. It's a one-time measurement we're going to get. Sure, I can cycle it 5 times, but it's not reflecting of the dynamics directly into things like cardiac output change. Mm-hmm. So these dynamic assessments are going to, I think, overtake static assessments, like a lactate measurement.
Yeah.
And we're going to start to gear our resuscitation phase of sepsis more to these dynamic ones, instead of saying, hey, keep giving fluid until the lactate's less than 4. We're going to start to say, hey, give fluids until their carotid flow time is, less than 7, or they're now normotensive. We're going to use these things that are very patient specific to exactly what we're targeting on the patient.
Wow, I am so excited to see what that does to outcomes. Like, I can't even, because it does feel like with sepsis management at the bedside, you really feel like whatever, it's not great. You hope for the best. It is kind of imprecise, because you're just trying to control this response the best
Absolutely.
you can, but it's not like just giving an antibiotic for a little infection that you're definitely going to see. I don't know. There's a helplessness of feeling involved when you're taking care of sepsis patients, because it's not like if you got all your pressors all maxed out and everything,
No. There's no guarantee on what you're doing is I can say for certain, I feel comfortable to saying, hey, if I start a vasopressor, I should expect 98.7% of the time I'm going to see a rise in blood pressure. There's nothing you can say on sepsis where hey, I'm going to give exactly 30 mLs and their cardiac output's going to be great. There's nothing concrete. There's not even a lab I can truly run to say they are severe sepsis or shock. And then you have to factor in that sepsis is affected by every other morbidity in the patient, CHF, renal insufficiency. It's all going to play in. That's why, our responses are different. I can get stung by a bee, be fine. You get stung and your reaction and response is completely different. So everyone's body responds so differently in the sepsis world that there is nothing prescriptive you can truly give them. So by introducing these things that are more patient-specific but go along the lines of the goals of sepsis resuscitation, I think are going to be key.
Man, this was an insightful interview, let me tell you. That was great.
Good.
I can't wait to make all these blog posts and things to talk about all your points. This is wonderful.
Totally.
Well, thank you so much for being on the podcast. This was wonderful.
I appreciate your time. And, I just want to say, everyone who's out there at the bedside, whether you're in leadership or you're taking care of the patients, just know every action that you do and every day you come to work and give it your 100, you're changing someone's life, whether it's that patient or that family's. And at the end of the day, that's always going to be our goal. So thank you.
I love it. What a great note to end on. Thank you so much.
Thank you so much. Have a great day.
Thank you guys so much for listening. I hope you enjoyed my conversation with Jaclyn. Super insightful, right? Amazing. Exceeded expectations. Absolutely. So make sure you if you have a comment, you want to ask a question, if you're watching this on YouTube, drop a comment, make sure you subscribe, you do all the things. Those are easy, free ways to support, and we appreciate your time. Make sure you're on our email list. We'll have a link in the description as well. Stay up to date on all fresh RN things. All right. Thanks, nurses. Stay fresh.